You're listening to He Said, a Cardiology Board Review Series. No fluff, just facts.
This episode is about stress testing. We'll talk about running an exercise treadmill stress test. Then we'll focus on the EKG component of stress testing, exercise alternatives to treadmill, use of adenosine and regadenoson, interpreting and reporting SPECT and PET, and artifacts on nuclear stress tests. So let's start with the exercise stress test. Exercise treadmill testing is a safe procedure with a mortality of less than 0.01% and a risk of MI of less than 0.04%. In terms of eligibility for exercise stress testing, the EKG component of stress testing will be uninterpretable if there is baseline left bundle branch block, left ventricular hypertrophy, Wolff-Parkinson-White pattern, resting STT segment abnormality, digoxin use, or V-pacing. If any of these EKG abnormalities are present at baseline, you will need to do an imaging-based stress test. In terms of contraindications, surprisingly, abdominal aortic aneurysm is not a contraindication to exercise treadmill testing, despite the theoretical risk of abdominal aortic rupture due to increased wall stress. HOCM and severe AS are contraindications to exercise treadmill testing due to the inability of cardiac output to compensate for peripheral vasodilation during exercise. Patients with unstable angina should skip stress testing and go to coronary angiography. Exercise stress testing should not be done during acute myocarditis, as there is an increased risk of exercise-associated sudden death if you try and exercise a patient with acute myocarditis. The upgrade to imaging stress modalities over EKG-only treadmill stress testing is not indicated in low or intermediate risk patients. It's a class 3 recommendation. So if you're recommending it, you should say in your note if they have a family history of coronary artery disease, or if they have diabetes, or if previous risk assessment testing suggests a high risk of coronary artery disease, such as a CAC score exceeding 400, or if they have other traditional or non-traditional risk factors. In terms of achieving sufficient stress, the heart rate response to exercise is blunted in elderly patients due to decreased beta-adrenergic responsiveness. That is why the predicted maximum heart rate decreases with age, estimated at 220 minus age in years. Know the formula for calculating the Duke treadmill score. Using the standard Bruce protocol, and the Duke treadmill score is calculated as follows: exercise duration in minutes minus 4 times the angina index minus 5 times the maximum ST deviation in millimeters. The angina index is 0, 1, or 2, depending on whether the patient had absence of angina, developed angina that did not limit exercise, or had angina limiting exercise. A low-risk Duke treadmill score is greater than positive 5 and indicates a 5-year survival of more than 97%. An intermediate Duke treadmill score of negative 10 to positive 4 is associated with a 5-year survival of 90%. A high-risk Duke treadmill score of negative 10 or lower, meaning negative 10 or more negative, is associated with a 5-year survival of just 65%. In normal individuals, cardiac output rises 4-fold to 6-fold above basal levels during maximum exercise. The average stroke volume remains constant with age. The observed decline in maximum cardiac output with age is primarily due to the blunted heart rate response. Maximal aerobic capacity, VO2 max, declines 8% to 10% per decade in sedentary individuals, such that there is a 50% fall between ages 30 and 80 years. If systolic blood pressure declines during exercise or fails to rise at least 120 millimeters of mercury, that is called exertional hypotension, and that indicates underlying multivessel or left main CAD. Other causes of exertional hypotension are hypovolemia, ventricular outflow tract obstruction, vasovagal reactions, cardiomyopathy, arrhythmias, and prolonged vigorous exercise. If systolic blood pressure declines after exercise, i.e., during the resting period, that does not necessarily suggest CAD. Diastolic blood pressure normally does not change significantly during aerobic exercise, such as running, swimming, cycling, or dancing. But during isometric exercise, such as planking or wall sits, diastolic blood pressure increases along with systolic blood pressure. What are the absolute indications for early termination of exercise? ST segment elevation more than 1 millimeter in leads without pre existing Q waves because of prior MI. Systolic blood pressure drop of more than 10 millimeters of mercury despite an increase in workload when accompanied by any other evidence of ischemia. Moderate to severe angina, CNS symptoms, signs of poor perfusion such as pallor, cyanosis, cold skin, sustained VT, second degree or third degree AV block, i.e., arrhythmias that interfere with cardiac output, technical difficulties with the equipment for monitoring systolic blood pressure or ECG, or patient request to stop. Those are the absolute indications for early termination of exercise. Now, how about the relative indications for early termination of exercise? These include marked ST depression of at least 2 millimeters, systolic blood pressure drop of over 10 millimeters of mercury despite an increase in workload in the absence of any other evidence of ischemia, increasing chest pain, fatigue, shortness of breath, wheezing, leg cramps, or claudication, multifocal ectopy, ventricular triples, supraventricular tachycardia, and bradyarrhythmias, i.e., arrhythmias that have the potential to become more complex or interfere with hemodynamic instability. Exaggerated hypertensive response with systolic blood pressure exceeding 250 or diastolic blood pressure exceeding 115, or development of bundle branch block that cannot immediately be distinguished from ventricular tachycardia. These are the relative indications for early termination of exercise. Now let's hone in on the EKG component of exercise testing. ST segment displacement is the main way ischemia is detected during exercise testing. ST depression is the most common indication of ischemia, whereas ST elevation in a lead without pathologic Q waves is found only in 1% of patients with obstructive coronary artery disease during exercise testing. J-point depressions with upsloping ST segments are a normal finding during exercise. The correct isoelectric reference point for the ST segment on a 12-lead EKG is the TP segment. However, because the TP segment is shortened during exercise, the PQ junction is instead chosen as the reference point to decide whether there is ST elevation or depression. In normal individuals who have an early repolarization pattern on resting ECG, the chronically elevated J point should return to baseline during exercise. What's the normal ECG response to stress testing? Your QRS complex is going to decrease in size. Your PR, QRS, and QT intervals are going to shorten. Everything shortens since heart rate rise brings about shortening of the RR interval. You're going to have J point depression resulting in an upsloping ST segment, but check that the ST segment returns to baseline. It should return to baseline by 80 milliseconds. That's 2 little squares to the right. Your PR segment may downslope in inferior leads. Your R wave amplitude may decrease when heart rate exceeds 130. Your P wave amplitude may decrease, and your T wave amplitude may decrease. These are all normal ECG responses to stress testing. How about abnormal ST segments change criteria in response to stress testing? ST depressions have to be at least 1 millimeter and have to be horizontal or downsloping to be considered bad. The ST depressions have to occur on 3 consecutive beats. Remember to measure 80 milliseconds, which is two small boxes after the J point, and compare relative to the PQ point, not the TP segment. Note, upsloping ST depressions are rarely true positives for obstructive CAD. ST elevations have to be at least 1 millimeter. For ST elevations, if there is a Q wave before it, then it's either an aneurysm or a wall motion abnormality, not necessarily an ischemic response. Exercise ECG findings that suggest multivessel or left main CAD are as follows: ST depression of 2 millimeters or more involving 5 or more leads, ST depression persisting 5 or more minutes into recovery, ST elevation in any lead except AVR, failure to increase systolic blood pressure by 10, sustained decrease in systolic blood pressure of 10 or more, or sustained or symptomatic VT. These are exercise ECG findings that suggest multivessel or left main CAD. Interestingly, the distribution of ST segment depressions during exercise testing correlates poorly with the location of coronary stenoses, but the location of ST elevations in leads that do not already contain pathologic Q waves does correlate well with the location of coronary stenoses. ECG on exercise stress cannot be interpreted if there is baseline LV hypertrophy, left bundle branch block, paced ventricular rhythm, digoxin use, or pre-excitation syndrome. It's common to have for right bundle branch block to have exercise-induced ST depression in V1 to V4, and that is non-diagnostic for ischemia. ST segmentation changes in V5 to V6 to an AVF, on the other hand, remain interpretable in patients with right bundle branch block. Digoxin can accentuate ischemic exercise-induced ST segmented changes, even if the resting ECG has no ST depression. The development of left bundle branch block during exercise is predictive of subsequent progression to permanent left bundle branch block. Patients with exercise-induced left bundle branch block also have a threefold increase in the risk of death or MACE compared to patients without exercise-induced left bundle branch block. Frequent ventricular ectopy in the early post-exercise phase predicts a worse long-term cardiac prognosis than ectopy that only occurs during exercise. Supraventricular tachycardia during exercise testing occurs in 4 to 10% of individuals without CAD and 40% of individuals with CAD. Sustained supraventricular tachycardia, which occurs in 1% of individuals undergoing exercise testing, is not diagnostic for ischemic heart disease. Patients with known pre-excitation, such as Wolff-Parkinson-White syndrome, only rarely experience tachyarrhythmias during exercise testing because the catecholamine response to exercise promotes antegrade conduction through the atrioventricular node. In fact, the delta wave disappears during exercise in 20 to 50% of patients with WPW syndrome. Now, how about exercise alternatives to treadmill? The standard Bruce protocol has a large increase in oxygen consumption from one stage stepping up to the next, which limits its ability to be used in patients who are elderly, deconditioned, or ill with other comorbidities. In such patients, a modified Bruce protocol or a Naughton or Weber protocol, which use 1 to 2 minute stages with only 1 MET increases per stage, can be done. Bicycle exercise protocols, which can be done for patients who cannot run on a treadmill, achieve maximum heart rate similar to treadmill tests, but maximal oxygen consumption less than treadmill tests. Arm crank ergometry can be used for patients who cannot perform leg exercise, such as patients with severe PAD. Arm protocols typically produce a higher heart rate and blood pressure response for a given workload than leg exercise protocols. However, the maximum heart rate achieved during arm ergometry testing is typically only 70% of that achieved during treadmill or bicycle tests. Maximal oxygen consumption and minute ventilation are also lower for arm crank ergometry than for leg exercise. Now, we'll talk about use of adenosine and regadenoson during stress testing. Use of adenosine, regadenoson, or dipyridamole for pharmacologic stress testing in a patient with significant CAD will cause vasodilation and increase coronary blood flow in healthy coronary arteries, whereas atherosclerotic arteries tend to already be maximally dilated distal to the site of significant stenosis at baseline. As a result, in a positive regadenoson or adenosine or dipyridamole nuclear stress test, heterogeneity of myocardial perfusion is demonstrated, but does not actually provoke myocardial ischemia in the majority of patients with CAD, unlike exercise stress testing. Dipyridamole acts by inhibiting the cellular uptake and intracellular breakdown of adenosine, increasing the concentration of adenosine in the circulation. The increased adenosine will cause increased activation of adenosine A2A receptors, resulting in vasodilation and increased coronary blood flow in healthy coronary arteries. If chest pain occurs without ECG changes in a pharmacologic stress test, it is due to stimulation of adenosine A1 receptors and has no prognostic significance. But if there are ischemic SC depressions, that correlates with the presence of multiple perfusion defects and extensive CAD. Adenosine, regadenoson, and dipyridamole cause bronchospasm by stimulation of the adenosine A2B receptor, so it should not be used in patients with active COPD exacerbation, although it can still be used with caution in patients with history of COPD without active exacerbation. In situations where you're concerned that you cannot use adenosine, regadenoson, and dipyridamole because of COPD, dobutamine can be used instead. Dobutamine increases myocardial oxygen demand by augmenting myocardial contractility, heart rate, and blood pressure, causing an increase in coronary blood flow similar to that of physical exercise, but less than that caused by dipyridamole or adenosine. In patients with left bundle branch block or a paced ventricular rhythm, there is a higher rate of false positive reversible perfusion defects involving the septum in these patients with exercise nuclear stress tests compared with vasodilator nuclear stress tests. Therefore, in patients with left bundle branch block or a paced ventricular rhythm, vasodilator SPECT or vasodilator stress echocardiography are the preferred imaging modalities, even if they are able to exercise. During vasodilator stress testing, a rate-related right bundle branch block may occur due to reflex tachycardia caused by vasodilator stress agents and is not specific for ischemia. Adenosine and related vasodilator stress agents may cause transient atrioventricular block via their action on the adenosine A1 receptor. This does not represent ischemia or organic conduction system disease. Xanthine derivatives such as theophylline and caffeine compete for adenosine receptors, so consumption of coffee or theophylline before the pharmacologic stress test can cause a false negative study. What are the indications for giving aminophylline to reverse regadenoson? There's severe hypotension, defined as systolic blood pressure less than 80, development of symptomatic persistent second degree or third degree heart block, wheezing, severe chest pain with ST depression of 2 millimeters or greater, signs of poor perfusion, pallor, cyanosis, or cold skin, technical difficulties with the equipment for monitoring systolic blood pressure or ECG, or patient request to stop. Regardless of whether it is an exercise nuclear stress test or a pharmacologic nuclear stress test, radiotracer agents such as technetium-99m, sestamib, or thallium-201 should be injected 1 to 2 minutes before the end of exercise to allow accumulation of the radiotracer at a steady ischemic state. Now, we'll go over a systematic approach for interpreting and reporting SPECT and PET. SPECT and PET perfusion images are reported according to a 17-segment heart model on a 0 to 4 scale, where 0 refers to normal perfusion, that's normal tracer uptake, 1, 2, and 3 refer to mild or equivocal, moderate, and severe reduction in tracer uptake, and 4 refers to complete absence of tracer. The sum of the scores across the 17 segments is known as the sum stress score, and summed rest score, SSS and SRS, at stress and rest, respectively. And the difference is the sum difference score, or SDS. The percent myocardium involved is estimated by taking the SSS, or SDS, and dividing by 68, because 4 times 17 is 68. For example, an SSS, summed stress score, of 18 corresponds to 26% hypoperfused left ventricle, because 18 divided by 68 is 26%. The size of the defect is categorized as small as if it involves 1 to 2 segments, corresponding to 5 to 10% of the LV, moderate if it involves 3 to 4 segments, corresponding to 15 to 20% of the LV, and large if it involves 5 or more segments, corresponding to more than 20% of the LV. The severity of the defect tends to be determined visually and subjectively by the reader, but by textbooks, the defect is mild if the sum stress score is 4 to 8, moderate if 9 to 13, and severe if over 13, and normal if the sum stress score is 0 to 3. A reversible defect is a defect that is either present that is present on stress but absent or less severe on stress, and indicates either ischemia or non-transmural subendocardial scar. A fixed defect is a defect that is equally present on stress and at rest and indicates scar. Wall motion should be abnormal in scar. Normal wall motion in the setting of a fixed perfusion defect should raise concern for attenuation artifact instead. What is TID? Transient ischemic dilation, or TID, is when you have a ratio greater than 1.2 between stress left ventricular volume and rest left ventricular volume. It is 1.22 if using a dual isotope protocol, or 1.19 using a technetium-99 tracer for both rest and stress perfusion imaging. Transient ischemic dilation refers to the phenomenon where the LV cavity appears larger in the stress images than the rest images, due to extensive stress-induced ischemia with transient LV dysfunction and dilation. Another mechanism for TID is that there may be diffuse microvascular disease that causes global subendocardial ischemia with stress, such that the internal border of the left ventricle has reduced radiotracer uptake. TID usually indicates either left main or severe multivessel coronary artery disease. However, women and patients with diabetes mellitus may show TID but turn out to have normal or nearly normal perfusion. In contrast to TID, LV dilation that is present both at rest and with stress would indicate a dilated cardiomyopathy at baseline. What are the high-risk features on nuclear stress testing? High risk meaning more than a 3% annual mortality. There's stress-induced large perfusion defects, especially if it's anterior. Stress-induced multiple perfusion defects of moderate size, indicating multiple coronary arteries are affected. Stress-induced transient ischemic dilation, more than 1.2, as we mentioned earlier. Severe reduction in global coronary flow reserve, can be less than 1.5 or less than 2.0, depending on your local machine. That's only on PET, not on SPECT. There's right ventricular uptake, increased lung uptake, and EF less than 45% on stress. All of these are high-risk features on nuclear stress testing that are associated with a more than 3% annual mortality. Increased lung uptake after stress is a marker of elevated LV end diastolic pressure and occurs if there is depressed LV function, extensive ischemia, or multivessel CAD. Increased RV tracer uptake after stress is a specific marker for severe multivessel or left main disease. Now, we talked about the high-risk features in MPI. Let's also mention the intermediate and low-risk features. Intermediate features on MPI are associated with a 1 to 3% annual mortality, and they are stress-induced and moderate perfusion defect without LV dilation or without increased lung uptake of tracer. Also, intermediate decrease in the global coronary flow reserve somewhere around 1.5 to 2.0. That one, of course, is only on PET and not on SPECT. Now, the low risk features on MPI, which are associated with a less than 1% annual mortality, are normal perfusion at rest and with stress, and normal global coronary flow reserve exceeding 2.0, and that's only on PET. The combination of clinical and myocardial perfusion data is more predictive than a combination of clinical and cardiac catheterization data, surprisingly. Supposedly, even when angiographic CAD is present, a normal myocardial perfusion study confers a low risk of subsequent cardiovascular events at less than 1% per year. Now, we'll close out this episode by going over nuclear stress test artifacts. Breast attenuation artifact appears as a fixed defect on the anterior or anterolateral wall. It should have normal wall motion on the gated images. If the fixed defect has abnormal wall motion on the gated images, then it is prior infarct. Next, diaphragmatic attenuation artifact appears as a fixed defect in the inferior wall instead of the anterior anterolateral wall of breast attenuation artifact. Diaphragmatic attenuation artifact occurs because of the diaphragm's position between the heart and the detector of the scanner, which can absorb some of the emitted gamma rays, leading to an apparent defect in the inferior wall of the LV. You can mitigate this by using upright imaging or prone positioning. Next, GI or subdiaphragmatic attenuation artifact appears as bright uptake in the GI system, leading to apparent defects in the inferior or lateral walls. It occurs due to increased radioisotope uptake by the liver or bowel, particularly after stress when blood flow to GI organs increases. Remember that all of these, quote, counts are relative. So if you have significant GI uptake, then relative to that GI uptake, the inferior and lateral walls of the LV is going to seem like there's a perfusion defect. You can mitigate this by using delayed imaging. Encourage the patient to drink water and move to clear the isotope from the GI tract. Next, motion artifact. Motion artifact appears as a linear defect or a random step line between adjacent slices on reconstructed images. This can be mitigated by using software correction techniques or by re-imaging the patient. Next, gating artifact. Gating artifact appears as an inaccurate-looking LV function assessment or wall motion abnormality. It occurs when there is incorrect synchronization of image acquisition with the cardiac cycle due to arrhythmias or variability in heart rate. You can mitigate this by ensuring proper ECG synchronization, using arrhythmia rejection algorithms, or re-imaging the patient when the arrhythmia is resolved. Then you also have soft tissue attenuation that appears as fixed defects. This can occur from soft tissues in the chest wall, including subcutaneous fat in obese patients. You can mitigate this by using CT with attenuation correction. So we have gone over many different aspects of stress testing, including appropriateness of exercise stress testing, interpreting the EKG component of exercise testing, exercise alternatives to treadmill, use of adenosine and regadenoson and dobutamine, interpreting and reporting SPECT and PET, as well as common artifacts to know about nuclear stress testing. That's all, and in the next episode, we will talk about anatomic testing in relation to stress testing.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.